night, intracranial extension, medial to cavernous sinus, invasion, feeders from ICA, you tend to leave the tumor. Young age is the most important factor. If the patient gets the tumor at 9 years of age, you have to be aggressive while remove the bone very well. Embolization, okay, if facilities are available. For grade 2, we do not favor embolization. Grade 3 and 4, it make a difference. So does not make a difference in, you can see in the above figure, but in the lower figure when there is a maze and the ICA figures, it gives us a point of view that you can have a good control and can remove the tumor. The one thing which I want to highlight is the people in primary surgery sometimes ligate the ECA. If there is some residual after ligation of ECA, we see that all the feeders are from ICA. And these are the most difficult cases to handle. You have to have a good control of ICA in these cases, and endoscopic approach, I would not say the beginners to do it. And we will always believe that you can see that the feeders are also from the posterior circulations. You can see that feeder in the last. This we done with the mid-phase degloving endoscope assisted. This is our classification which came in the early part of this year. In the maxillofacial surgery, European Journal of Maxillofacial, where we describe the tumors of the stage 3 according to the blood supply, either they are from ICA or ECA or both. And we propose now that if the tumor is 1, 2 and 3A, it can be handled with endoscopic, but 3B and onwards tumors should not be handled endoscopic. So the most important thing in JNA is, one is vascular, we have already talked, the other is bone removal. Bone removal is paramount. If it is grade 1 GNA, you can go directly to the pharynx, but you have to remove the posterior wall of the septum. But if the JNA is going here in a pterygopalatine fossa and sphenopalatine foramen, then you can just remove the medial wall of maxilla and can go here. We have already talked about it, Alex talked about it. If the tumor is going into infratemporal fossa proper or in the lateral extent, then you have to remove the modified Denker approach. Then you have to do something to nasolacrimal duct. You can see here that the nasolacrimal duct here, and that has not to be transected if the tumor is up to this pterygopalatine fossa and sphenopalatine foramen. If it is going beyond, you need to do a modified Denkers. So a specific area, this is pterygoid, which is important. The other is the spheno suture. You can have the tumor going in from the foramen open. The advantage of endoscopic approach is you can see this is a tumor which we think has removed fully. But on closer inspection, we can this is the maxillary artery, this is the posterior one which has been removed, this is the middle turbinate, the lower part, and you can see the small bit of tumor which is coming out. So even if you do mid-phase degloving, put the endoscope, see if all the foramens has been addressed, and just so the surgical approach planning for stage 1, endoscopic endonasal. In the stage 2, you can do if you have experience in endoscopic endonasal or mid-phase transpalatal. Stage 3 and B, endoscopic endonasal mid-phase. Stage 4 will need some stage frontotemporal keratomy, or you can go at the same stage. This is, I want to highlight, no facial incision is to be given in JNA. All JNA can be removed from either mid-phase degloving or from endoscopic approach or from the lateral part. No facial incision because the patient has at least 50 to 60 years to live and he cannot live with the scars. Just a point, facial degloving, everybody knows facial degloving. I will skip you can see that all the nasopharynx, the skull base, all of the central skull base is visible. You can see all the tumors, even you can see the tumor in paracavernous, infraorbital fissure. So this is a few of the example of a stage 3A tumor which has been removed, and you can see the whole specimen. I will come to that. This is another tumors. The tumor is even going parapharyngeal, and it is adjacent to the carotid. You can see the carotid there, adjacent to the carotid, lateral to the carotid. So this has all been removed by mid-phase. In mid-phase, either if you are not comfortable with endoscope, you put a microscope and dissect on the periphery of the tumor. We just start tumor from periphery and then start dissecting and then follow the tumor. Follow the tumor into the foramen and everywhere. But before removing, remove the bone of the foramen. So this is the post-op picture. This is what the scar. This is endoscope assisted mid-phase. This is the cavity after the tumor removal. Like people say that one of the pterygoid veins, but I want to say that JNA has a very beautiful tumors. You can see this one. That this tumor is into a pterygoid marrow itself. But you can see how big the space there to address the pterygoid. Most of the time, I have drilled maybe 1 or 2 pterygoid in this so many cases. But you directly, if you are on the lateral surface of the tumor, you are here, you can go in and remove the tumor from there. So, this is the post-op cases. This is another cases. You can see this is all the tumor. This is a paracavernous extension here. This is all tumors can be handled by this approaches. You can see this tumor. The another is that your specimen, if it come out in one piece, you can match like you can match that this is in the nasal cavity, this is infratemporal fossa, this is pterygopalatine, this is paracavernous, this is the sphenoid sinus. So you can match the specimen. If there is any breach in the continuity of the specimen, you can count that what is the breach. Like in this case, if it is a breach, we try to measure out from where we have removed. So if you remove one piece tumor, then it's a good thing. You can see from which foramen, go back to the scan and see from which foramen the tumor has been removed or not removed. So no need to do any post-op and put the endoscope there and see all the foramens. There will always be, if there is the foramen, if the JNA residual is there in the foramen, there will be always, once you do some suction, there will be always some bleeding. And if the bleeding is there, just explore that area, remove some part of the bone and go inside the foramen. All the foramens can be addressed. The only foramen which I find it difficult is the foramen ovale. And I said, like in this case has been done, a stage frontotemporal keratomy has been done, and this has been removed. This is my cases where I have left the tumor. This is you see this is in the foramen ovale going into and then cavernous sinus. Even the neurosurgeon said that if you go into inside the cavernous sinus, then there is a chance of complete ophthalmology. These 2 patients are being followed and on radiotherapy since 2.5 years. The recent paper has come up. People will not agree, but long-term treatment has been come up, and it is a good alternative to prevent a big morbidity. The other thing is flutamide in JNA we have recently started, especially if the tumor is already compressing on the optic nerve. Then if you are not possible to do immediate surgery or it is invading the cavernous sinus, at least 20%, 15 to 20% tumor reduction is possible with flutamide, especially if patient is post-pubertal. It does not work in pre-pubertal cases, but we have excellent result, and a cavernous sinus lesion can be removed endoscopically or by mid-vis developing without disturbing the cavernous sinus. Just the bleeding will be there from the medial wall of cavernous sinus, which can be easily handled as shown in pituitary surgery or in other surgery. As we will take a piece of surgicel and put gel form in between in the inside of the surgicel and put it there, put a patty, and the cavernous sinus bleed stops just like anything. So this is the statistics. I want to say that in stage 1 and 2, you can see that the bleeding is very less, 100 and 130 ml. And the duration of the stay, admission to discharge is 4 days. But in a stage 3, the bleeding loss is more even in endoscopic cases. Maybe that we gain more experience. But in endoscope, in the assisted courses, you can see that in stage 3, the bleeding is 240 ml. And stage 3D is embolized, 3A is not embolized. So take home message is then till stage 3 can be done without difficulty, in most cases by endoscopy. Look for foramens involved and address them. That is the most important point while considering the extent. A good CT scan, and whenever needed an MRI, if there is a cavernous extension, then MRI is must to look that how, because sometimes you will see that there is cavernous extension into the CT scan. But once you get your MRI done, you will know that where the cavernous sinus is and where the JNA itself is, because it is a highly enhancing tumors. So endoscopic approach and mid-phase are now standard of care. All textbook and everything, the recent literature says that the other approaches, I am not saying it cannot be done, but should be avoided because of the facial scar. Stage 4 tumor require multidisciplinary treatment. It's required neurosurgeon, it's required ENT surgeon, maybe a person in the radiotherapy and all that. And thank you, because the scar matters. Thank you for giving me a opportunity.